Okay. Well, we're supposed to be talking to Shawn of DHHR today. Uh, and that is sorry, that is a conversation I think is really timely. Timely in part because of the fact that this month is National HIV Testing Day. And also because of the current outbreaks that we have going on in West Virginia. And what I see is I think a shift that we should be having in the conversation about HIV in West Virginia and actually throughout Appalachia, if not throughout rural America. And that's the switch I'm talking about is to maybe start having conversations more and more about the growing syndemics rather than simply having a conversation about HIV or hepatitis C or just about substance use disorder or just about harm reduction or about people who inject drugs or use drugs. I think as we look more and more, one of the things is that I think that we've got to get more people engaged in what I see as this growing syndemic across America, and I think we also have to maybe expand how we talk about it, who we invite to talk about it, and the people that we need to have us eradicate and fight it. I think that and some people may be a little more conservative on this concept than I, but I think that we have to maybe take a look at what's happening in many rural communities that are redder, and I mean that more conservative than they've ever been. But what does this mean for public health? And if we're going to have that conversation, I think we also have to have a conversation about the role of voter suppression in our rural communities, in our southern communities, and how it is that we need to have more people who have our same public health ideals engaged in politics and as elected officials in our local communities. And like I said, I think that it's because it's a conversation about a growing syndemic in America, HIV, viral hepatitis, substance use disorder. I think we also are seeing higher rates of poverty in these very same communities. And all of these things are certainly impacted by for everybody from who's our local dog catcher to who's on our city council or our town council or in our state houses, all the way up to who do we have in the House and the Senate. But I think that these things are a way in which we can start to have a conversation again that we have in many cases moved away from. We either talk about one, the other, or none. And when I say that, I mean that we talk about many of these issues as they impact or harm someone else's community, someone else's neighborhood, and most importantly, someone else's family. But the truth of the matter is that, I don't know who on this call can say that harm reduction, substance use disorder, or behavioral health, HIV, Hep C, or just, man, the stress of this pandemic hasn't impacted our families, our communities, our neighborhoods, us and the people that we love. So I'm hoping that Shawn will join us because I just think that this conversation is super timely. If not, I'm going to start picking on people who I know might be a bit of a subject matter expert on some of the things that I don't want to say rambling on because actually I've been just thinking about it a lot. That I think in West Virginia, when we saw Senator Tarr's bill pass through the House and get signed by the governor so quickly, many people were said, "Oh well, it'll never happen, never happen," and I actually thought it would happen from day one. I thought that. it didn't really support the goals of the governor's substance use disorder plan. I think that we have to think about how we're going to implement all of those things. And even when you look at the governor's plan for substance use disorder in West Virginia, it really does frame it around a syndemic, that all of these things, one being related to the other. But one of the things that doesn't happen is that we don't necessarily have that conversation. We don't have the conversation about how the HIV outbreak in West Virginia relates to the hepatitis C, B, and A outbreaks in West Virginia. And nor do we talk about how they all then relate to how we now see higher rates of fatal overdoses, higher rates of Hep C, higher rates of HIV, higher rates of poverty, fewer people getting vaccinated, and at the same time, uh, we become more and more conservative. I have a friend, Debbie Fuchowski, who lives in California, and we're good friends. We've been friends for I think probably 30 years at this point. And people may not believe it, but I have very conservative Republican friends. And she said, and I said, how did you end up so conservative? And she said, well, the more you have, the more you want to conserve. And I started thinking about that when I kind of just think about the condition we're in West Virginia. And I'm like, is it that we have more to conserve, or is that we just simply really do have much more to fight for and that we need to be fighting for and at the local, state, and county level? And I do. I just think that we can do it. I think we can fix it, but I think we have to start talking about it in a different way because I just don't think that we're that different in our approaches or belief about uh, public health. I don't think that we're that far apart on wanting to protect and save our families and to do the best that we can for our communities and our towns. Um, and so I think I'm seeing a lot of what's going on in West Virginia and throughout Appalachia and throughout many of the jurisdictions that, again, are relatively red and conservative. For example, Indiana is thinking about rolling back its harm reduction programs. And, they were the model for many of the states that saw an opioid crisis blaze through again towns, families, homes, individuals. So I think that the idea that you roll back now just seems counterintuitive to me, coming out of the ending of a pandemic where people have been isolated and likely are probably going to use for the first time because they're coming out of isolation or have been in isolation and started using in isolation and need resources more and more. And again, this is a call about HIV, but again, it's about the syndemic that surrounds it. That we're not seeing an epidemic like we saw in the early '90s or 2000s in urban jurisdictions in D.C., Baltimore, L.A., New York. We're seeing something completely different, and we have to have a completely different response and action plan. Now this guy doesn't know I'm gonna call on him, and I'm sorry I'm doing it, but my other my speaker didn't show up, so I'm gonna have to do it. Andrew Bell, I see you on this call, and so I'm gonna ask you to you don't have to get on camera because you might not put on all of your makeup. Oh, there you go. You did put on all your makeup, and you look good too, sir. Maybe what are you seeing? What I'm saying around other parts of the country. So, folks that don't know Andrew, Andrew's a consultant with a group called JBS, and they're doing a lot of work to support what's called R Corp grantees. And people who know Amy Snodgrass is an R Corp grantee. My God, Morgan County Partnership. For people who know them, they have been an R Corp grantee in the past, but he provides what's called technical assistance and training for those grantees, and those grantees are out of the HRSA, Health Resources Service Administration's Office on Rural Health Policy. Rural Health Policy, I think if I have it right. So, but Andrew, I just want to ask, are you seeing the stuff around rural America, or is it just me?
Just you, Tony. We are starting to see a little bit about it. I think the most alarming or concerning piece is not that it's ubiquitous yet, but that the efforts that are happening to shut down syringe service programs are going to be seen as models for opportunistic legislators. There was an effort in Western Maryland just before the pandemic, a guy who was a state legislator who was running for Congress on a sort of Trumpist platform, decided to go after the syringe service program there. He wanted it carved out of the legality for the state. They built a really strong foundation of relationships with families, recovery community, cops, and so and others. And so they had a pretty diverse coalition. When he came and presented a lot of misinformation to the county commissioners, who then signed a letter of support. The next week, there were a bunch of people testifying in front of them about how they'd messed up, including an officer in uniform. And the family, he'd used a story about a child who'd been stuck with a needle, and the child's parents were there testifying how they supported the program, and they were upset with the legislator for using their story. So we started to see this a little bit before. We're seeing more of it now. A colleague of mine talked about it as the sort of exhaustion of empathy. People have been cooped up, and a lot of other things have happened. And so a lot of time people are looking for scapegoats. And so my big concern is that we've been having a sort of different public health conversation for not great reasons, both because we couldn't hide the bodies anymore. We couldn't pretend this wasn't an issue or a problem, starting really with the third wave of the crisis. But then particularly when, 1 to 200 white folks in southern Indiana got HIV, it meant that in the political imagination, it couldn't be a problem for those people over there. And so I think that sort of subterranean is probably generous. That racism was a big sort of shift in our resources and policy and urgency since 2015, but we also never really grappled with what we'd actually need to do. Or how we'd actually need to understand it. So a lot of the money's been spent in ways that are mixed and not great, and that public health conversation been happening over here. And so I think there've been some successes. There've been a new wave of laws and some expansion of syringe service programs, but not a real sort of adoption of harm reduction, particularly as an approach. And I think that the hinge moment that we might be at now is whereas this public health conversation was happening over here that was held back by stigma or a lack of our willingness to confront sort of how this is a crisis of us, right? This isn't a crisis of substance use disorder. This is a shift in the street drug supply, and there's things that we know that would fix it. And we're not doing those things to fix it. And those things are in like a CDC document that was released under the Trump administration. And so if you just take the CDC's evidence-based strategies for preventing opioid overdose, you take the 5 principles they endorse and the 10 interventions, and you ask, like, is my community doing these things? Are we open to doing these things? I think it makes it really clear that.
Whoa, yeah. Easy. I'm the fast talker in the group. You I feel like you fast, like my father used to say.
I thought I was going to get traffic cops at some point.
No. This is not that kind of party. So you're fast talking me. So what are these 5 things that you say that communities should be doing? Do you know them off the top of your head? Is this something? Yeah, all right, you do. All right, well, tell us what are those 5 things that, according to this document, that at the CDC that we should all be doing?
So if someone beats me to it in the chat box, after I'm saying it, I'll try to throw it in the chat box. It's the CDC Purple Book. It's colloquially known as Evidence-Based Strategies for Preventing Opioid Overdose. What's working in America? So it looks at what is working with existing law and policy. There are 4 guiding principles gleaned from previous public health crises, including the HIV epidemic. And they are know your epidemic, know your response, nothing about us without us, make collaboration your strategy, and meet people where they're at. And so you'll notice that at no point in this document does it say the words harm reduction. But in 3, arguably 4, definitely 2 of those principles is harm reduction. And the one that we're failing most abjectly at is nothing about us without us. And the other ones, there's sort of mixed areas of success. And I usually use know your epidemic, know your response to have my grantees sort of refocus their community of folks have most absorbed the prescription narrative and are focused there, where if you focus on the prescription narrative as Maryland, as West Virginia did, you're going to see deaths increase rather than decrease, because you'll have people moving from a diverted prescription opioids to a more dangerous illicit market.
Wow. That was a lot, but I know you're a smart fella, and you can help us maybe understand so let me say this, and I know that there are people. I'm looking at some of the people who are on the call. I have my good friend Amy Snodgrass. She's a grantee, so she's not going to say too much of nothing against you, because she's a grantee and she likes being a grantee, right, Amy Snodgrass?
I do.
And so, but I think I'm wondering if I have anyone on here from either DHHR or any sort of county health department, because I think that, Andrew, one of the things that I'm going to kind of play the devil's advocate on the other side of it, and I think part of why I want to see us start using different language and talking about this in terms of a syndemic is in part because of this. I think at one point we being CEG, had done a call on harm reduction. And man, I took it on the chin bad because people said, well, it wasn't people with lived experience on the panel that you put together. And that actually wasn't true. I mean, it wasn't the thing that people, myself included, led with. I mean, we talked about our jobs and our experience and other things, but, and I think that then other people had, different opinions about harm reduction. And so I think one of the things that happens, and I want to have a conversation about this a bit. One of the things that happens is that I think that people, I have experienced, let me rephrase that. I have experienced it where in group settings and group dynamics, making room for people who don't have lived experience, for people with lived experience can be hard. Making room for people who have lived experience in a different way, or who may not be harm reductionist, or maybe people who are Suboxone, buprenorphine users versus abstinence only folk. I think that how do we do a better job of making room for everyone at that table? Because I'm telling you, I've gotten it on the chin by people who I thought we were all on the same side, and they're like, "You're not on my side enough. You're too conservative. You're not on my side enough. It's you. I have to be the one that speaks." So how do we do that? How do we balance that out?
That's a great question. Tony, do you want to sort of restate or pare the question down? You did what I do, which is ask a question with so many options and moving pieces that by the end of it, people are sifting through. So I can hang with that question, but I want you to sort of focus it in. So I'm answering the part that you think is the most important.
How do we create an equitable space with differing approaches, not necessarily differing opinions, but differing approaches? I think people, like I said, at the end of the day, I think people want to either eliminate, prevent, treat, care for people living with HIV. I think people want to support, eliminate, address people's needs who use drugs. I think people want to address, eradicate, give people access to services who are people living with hepatitis. I think people want to help people be educated and understanding public health overall. But at some point, I feel like there's a crash. So, how do we make room, an equitable room, for people with the same, I think, goal, but different approaches? Maybe I can pare it down that much.
Yeah. Yeah, I think if I told you there was a silver bullet, I'd be a liar. And if I told you that there was like ways that this has happened really well in rural contexts within sort of institutional public health settings, that wouldn't be true. And so I think the first step is on the public. So I think that what I'm hearing from you, Tony, is that even if we want to do this, sometimes it goes bad. And how can we sort of anticipate the ways that there's going to be a clash of expectations and culture with different stakeholders and different levels of comfort? So how do we make sure that we can bend the system towards more responsiveness without breaking it and having nobody together anymore? Is that some of the question that I'm hearing?
I think it's simpler than that, right?
Great.
How do we all kind of have a healthy respect for different approaches to the work, right? I mean, Amy and Bree are doing research and programs over there with what they do, right? We do some policy and advocacy with what we do. We've got other groups that may run underground exchanges. We've got other groups that may do distribution. We've got, I mean, and the reality is that I don't know that we have different goals, but I swear I feel like sometimes a line gets drawn in the sand, and I just don't know how we can't. I feel like I'm having a Rodney King moment. Can't we all just get along?
Yeah.
Yeah, I said it. I did it.
I'm gonna try to say three things. I like what Martha has in the chat box, which is that it's about relationships. I think that one of the things we need to do is sort of manage our expectations. And so whenever we are or are dealing with a community that's absorbed a lot of trauma, we know that that the likelihood is that absorbed trauma there's gonna be some sort of momentum towards rehearsing it on one another. So that's a starting point. The three things that I'm gonna suggest are potential starting points is number one, on the public health side, to recognize or spotlight the imperative that we have failed at, which is including the folks, if we're talking about the overdose crisis, that are most impacted. So we've been in an overdose crisis. We haven't done that yet, and it's not just folks who are out in the streets with signs saying that. The CDC says that. If we're looking at the principles of trauma-informed care and particularly empowerment, choice, and voice, but others as well that SAMHSA endorses, SAMHSA says that. And so the very quick stories, I was at a NASTAD annual TA meeting. You probably heard this story, Tony, so forgive my repetition. I was in a room of 150 infectious disease providers, and I asked who works for an agency that practices the principles of trauma-informed care, and 95% of the hands go up. And I say, that's great. And I say, who works for an agency that serves people who are actively using drugs? And 95% of hands go up. And I say, that's great. So who has people who use drugs involved in the planning, evaluation, delivery of your services? And like 5 or 6 hands go up. And so the CDC released a technical package on syringe service programs. The number one recommended strategy is building partnerships with people who use drugs. And so just from within public health, we need to acknowledge that there are imperatives currently on the books from this federal government, from both administrations, that say this is something we have to do. So first, we just got to put up the mirror that this is imperative. We're not doing it right now. We do have to do it. The second piece is we need to be trauma-informed. And so, again, SAMHSA has been endorsing the principles of trauma-informed care since at least 5-10 years. And the first principle of trauma-informed care is safety, that everybody feel physically and psychologically safe. From the degree to which you're describing him and taking on the chin, Tony, it sounds like the container that was created in that space was not one that kept everybody safe or together, right? And the last principle, that's the first principle of trauma-informed care, but it connects pretty well with the last principle of trauma-informed care, which is about culture, right? So it's about addressing and acknowledging the dynamics of race, gender, culture, and other historic intersections of oppression, right? And so we're going to have to be always careful with the language in audiences where like they can't hear you after some certain words are said, but it is a balance there, right? So if we look just at the principles of trauma-informed care and start with those as a starting point, that's going to be a helpful piece. And then the prospect of cultural humility is something that I find often more useful than cultural competence because there are ways that I'm never going to understand someone else's experience. And so should I have some baselines? Should I have some like basic ignorance that's been removed? Yeah. But like I should also think that it's always going to be an ongoing learning process. And that everybody has something to learn. So I like what you were describing, Tony, in terms of we all have different roles to play. And so for us to do that, we need to know what they are. And we also need to be acknowledging those with each other. And so I could say more, but I don't want to be filibustering here, monopolizing the time.
Well,
The three starting points I would say are those three.
You're not. We call it in the Black church, we call it preaching. And that's kind of what you're doing a little bit. But and I don't think you're actually preaching to the choir because I think you know what I mean? I think I said I'm looking around of who is on the call. And like I say, I think everybody has a different role. And see, I think that trauma works both ways. And I think that sometimes it's that, and I'm just going to talk about my own personal experience, right? It's like, man, after I get beat up by, a drug users union, or I get beat up by underground, they're like, you don't care about us. And I'm like, but I do. I really, really do. I swear I do. And like, but I got to do this my way. I worked way too hard to be able to walk in the front door and to get this meeting. And you don't understand that this is a part of the you push, I pull, you pull, I push. This is how this all works. And so and I think that those of us who probably do more, I would say, advocacy and policy versus activism, and I'm making a distinction there, I think we have a little trauma too. And so we, when it comes time, I think it was Martha who said, build those relationships. I think we want to, but I think we get jumpy there too. I don't know. I think it goes both ways, and I'm just not sure how we get everybody who, how you get all these cats in a room full of rocking chairs, right? Because I think everybody's jumpy. And so, you've got your elected officials, they're jumpy. They're jumpy about who their voter is. They're jumpy about being reelected. They're jumpy about the public health implications of what they're doing. I think that that's just it. If everybody's jumpy, kind of what do we do? And Martha, can you say any more about kind of the partnerships that you have been able to develop in this space, in this endemic space, or in the harm reduction space, or in any space?
Well, I will say that I just kind of stumbled upon this meeting and I'm a little bit like, oh crap. I work in the Northern Panhandle as a state opioid response coalition engagement specialist, but I have been working in the prevention field since 2007. But I'm not sure. I'm afraid they might be way over my head here. I'm not sure. But I was just thinking, because now in this particular job, as opposed to my other jobs I've had, well, in all of them, I was really doing this, but in this job, I have like a regional position. So I realized through all this that, yes, I am missing people. I am missing maybe women, parenting women. I have been, or we as a whole, let's say, have been missing LGBTQ, maybe African American community, that it's not so much that the risk might be higher for them, with substance abuse, which is what I do. But that that getting the care, getting to the next step is where the barrier is. So that because of the system that we're all in, or however that works. So my current goal in this is that I'm getting paid to make sure everybody gets this who needs it. And so I am now really ringing out my community to try to find the groups that can actually get me to the populations that are not feeling like they are getting the information that's leading them to treatment, that's leading them to care, that's leading them to whatever. So I'm not sure if I'm missing your boat totally entirely. And if I am, I apologize.
No, you're you're right on the boat, because it sounds to me that you're saying that your role is really to do this work and prevention education work in the substance use disorder space. Am I understanding that right?
Correct. Yes.
Right?
Although HIV has been also is designated on my grant that I'm working under as a education around that, and just because those with substance use, the clusters are coming out as a result of substance use disorder, and my understanding of that.
Right. And so, I mean, so you're right on where, and I think that, so, and that's maybe exactly what I want to be talking about more and more, is that your substance use disorder work, I don't call them clusters anymore. I had a conversation with you. I don't call them, I mean, it's an outbreak. And I think words matter. Right. And when I say words matter, I think until we realize how bad this HIV problem is in West Virginia, I don't know that we see it as the crisis it is. And again, you know what I mean? And that's not on you. That's not me jumping on you. That's saying, that's what got me to, we've got to maybe talk about it in a different way. And I think people are tired of hearing about HIV. I think they're tired of hearing about substance use disorder. They're tired about hearing about. Yeah. And so I'm like, okay, let's give them a new word. Let's make them focus on the word syndemic, right? I mean, and I mean this very serious. I'm like, let's make them focus on a different word. By the time they go look up the word syndemic, then maybe they'll be like, okay, well, all right, I'm not as mad as I was when I first started. I mean,
I do a lot of like, listen, you are thinking this is not going to affect you. Well, guess what? You have a daughter that dates, or son. I have a daughter, so I go there. You have a daughter that's dating someone. You don't know if they're using substances, if they've used IV before, if they're sober now, if whatever. And that daughter then has contact, and you know what I'm saying? Like, I really bring it home to, you don't know. And then the kids of that person, then, nobody, eventually it's going to make its way, just like it did back in the 80s when we first had to deal with all this, to everybody. Right. And are you going to wait until then to care? That's kind of where, and I don't know, like my sister works for the CDC actually, but so I think I've heard cluster.
Cluster. Yeah. No, I mean, that's what I think that cluster language is, and because I had a conversation with a woman from CDC, I guess about a week or 2 weeks ago, and I specifically asked, like, why do we use cluster? And there was a very logical reason why. And I said, but at what point do we use outbreak? And she said, now.
That's cool.
She said, now. And I was like, okay, cool. So, and I mean, I just think it's really important that we make sure that we're talking about what we're talking about. And again, I just really feel like until we can get people to think about all three and if not more of these things, we will have a problem going forward. So
I am
I'm
going to use outbreak from here on out. Thank
yeah,
you.
yeah. You know, and so I've also got Catherine on here. And what do you say? There are tired people talking to them instead of them. They're tired of, Catherine, are you saying that they're tired of just like random people talking to them? Are you still here, Catherine, or did you leave?
I'm still here.
Okay. Which, I'm sorry, can you clarify what you're saying in the chat?
I'm a peer recovery support specialist, so I feel like I'm kind of in the trenches. And when I talk to people, you know, we do outreach and all of these organizations and resources reach out to people, but they feel like they're talking at them and down to them more than like with them and on their level. So it's like, we want to help you, but they don't feel that connection of genuinely anybody wants to help them.
So what do you think? Okay, so what do you think that we can do differently, or what do you think that we can do better? Is it that we need to implement more peer-based models? Is what can we do also to say, okay, you know, maybe this isn't a person talking down to you, maybe they're working on another piece of the puzzle. You know, how do we do both things?
I don't know.
I mean, because I think that, you know, I think that's a part of it. I think I have heard that many times that, you know, people with lived experience or people that are still actively using feel as though they're being talked down to. But, and I'm always like, but I think, is that what's really happening? Or is it that this is just a different piece of the work, addressing a different need in the problem? You know, I don't know. Anybody else got something or want to say something about this? Well, Catherine, before I let you off the hook here a bit, I think you actually hit the. I don't have my reading glasses on, so that's why you see me like squinting and bending and trying to read. But it says people get too passionate about their causes and forget not everyone may share it. And I think that I think maybe that's it too. You know, we get passionate about our cause, or we get passionate about our position, or we get passionate about, frankly, our role or our power or our sense of self-importance. I think that can play a negative role as well. Andrew, you put a ton of stuff in the chat. You've been over there just like dropping rhymes in the chat. You want to tell us what you put in the chat?
The first thing that's in there is the CDC Purple Book, which we talked about the principles and the 10 interventions they talk about, mostly center around MAT, harm reduction, and then sort of touch point partnerships. So whether that's emergency room or naloxone or MAT and corrections, that kind of thing. The second thing in the chat box, people were saying like, well, how do we actually do this? AIDS United put together a really great document. It's 2 pages long. And also another great thing about the CDC document is all of the interventions. They got a lot of pictures. It's 2 pages for each of these interventions, and they got a lot of receipts, right? So if you're looking for like a one-stop shop of how to do this well, and then how do you justify it, like it's all there. AIDS United puts together a great document. It's 2 pages long. Do more of this, do less of this, ask yourself these things about the meaningful involvement of people who use drugs. And earlier when Tony was asking, like, how do we, start? And then I think part of it is recognizing we talk about the stages of change. A lot of folks are going to be familiar with the stages of change, which comes from the trans-theoretical model of behavior change, which in the classic public health tradition, it takes like extraordinarily complicated words and ways to say really simple things. And so if you're not familiar with the stages of change, they are pre-contemplation, contemplation, planning, action, maintenance, and kind of recycling. And they're not linear. It's how behavior change happens. It comes out of a long time. And basically it's, you're not thinking about doing something, you're thinking about doing something, you're planning to do it, you're doing it, and you're maintaining it. Now, all those stages, you may be messing up. And like having a new workout plan in the new year is a good example that's often available to a lot of people. And so Carla DiClemente is a co-author of the Stages of Change. With my work, they did a webinar on the stages of change. And we pretty readily, if we know about them, apply them to folks who have substance use disorder, who have risky behaviors that might make them susceptible to HIV. We're really like ready to put stages of change and the need to change on our clients or folks that we're serving or coming alongside there. And so the stages of change, I would argue, are also useful in looking at our own community, right? Looking at ourselves. And so again, if we are in an overdose crisis, if Trump administration released a document in 2018 that is a pretty good map on how you reduce death, and most of us can get behind reducing death, and we're not comfortable or doing most of the things, then it's a reasonable question for us to ask ourselves why, and what stage of change are we in? And I think somebody made a really great point earlier in terms of folks are tired, right? And the group before this sort of current moment, the group or stakeholder group that had was most challenging to talk to, most challenging to get through to, were, in my experience, EMS and emergency department staff, because my lens on it is that they've been really unfairly an emergency response to a structural issue, and they're burnt out. They've reached a point of compassion fatigue, and at that point, that sort of stigma really sets in deep, and we might be seeing sort of a much broader contagion of that phenomenon happening right now. And that may be a place of pre-contemplation, and maybe nobody's going to hear anything until you hear them, right? And so when I have folks who are going to talk to EMS, the thing that I always tell them to say first is ask them how it's been for their folks. If what they hear, which is what they usually hear, is that it's been terrible, like we're burnt out, we're tired of going to the same call 6 different times. And the person who is calling 6 different times or having the call come for them to be revised 6 different times, they're probably tired of it too. And they may or may not have access to medication-assisted treatment. We know they won't have access to any places where safe consumption can occur. And so, like, they're not in an okay position either. It's resulting that the EMS are also in an unfair position. And then the blame, though, goes on the folks whose fault it also isn't. And so it's the stages of change in a webinar, the stages of change is the next thing in there. After that, we talked about cultural humility. The University of Texas has a great sort of blog series from one of their mental health centers. And it says 3 things to know. It's a great sort of starting point if cultural humility is new for someone. And then I really loved the balance you were trying to strike, Tony. And you were saying, like, you know, there's trauma all around. And like, we've got these different areas and these different groups who have trauma. And something that gets a lot of lip service, a lot of buzzwords, and not a lot of practice, particularly in the public health space, is restorative justice or restorative practices, which basically moves from, at its most simple, moves from looking at harm or wrongdoing as a crime that needs to be punished to harm that needs to be repaired. And something that also happens in these conversations is we may or may not be ready to talk about the impacts of race or racism. And so there's a little book of restorative justice. There's a series of these little books that are good introductions to this. Howard Zare is considered the godfather of restorative justice as a practice. It comes from indigenous practices, so he's not the inventor of it. He's the sort of collector of it as a discipline within sort of justice and public health spaces. Thanya Davis wrote a book called Race and Restorative Justice that just came out last year. So it's speaking to this moment. And she talks about the need for both the healer and the warrior, and talks about how, like, in restorative justice conversations, we're often coming with an orientation of the healer. And in conversations about race, we're often coming with the orientation of awards. And that both of those things are necessary, and both of those things are necessary to balance. The thing that I would say, Tony, to the balance that you're describing is whatever we're talking about, if we're going to be trauma informed, then we are creating that safety, which we're not always doing. And I feel like that's what you're hitting on really well, is like, it's not safe for this person, it's not safe for this person. And I think the other question is, where are we orienting, right? And so if it's a conversation about a syndemic, then we should be orienting towards the folks who are most vulnerable in that syndemic. And so if I have a lot of feelings about the fact that I'm going to say the wrong thing, so I'll move it to conversation about racism. There'll be conversation about racism where maybe I'm really worried I'm going to say the wrong thing, and I'm worried that I don't feel safe. And those things might be true, and they might be like necessary to be addressed to be able to have a functional conversation. They might not be the most important thing happening in that conversation. And if Tony and I are talking about racism, then like my feelings are going to be less important to orient around than Tony's. And my experience or my knowledge or my expertise is going to be less connected to my lived experience than Tony's in this country, where racism is primarily and especially directed at people of color.
You know, Andrew, you said, you know, as a couple of people I know say, you said a lot, and it's all very important. I think that we are in some heavy moments, right? And I do think that we don't give people being tired enough room. Yes, I've heard it from EMS workers as well. I don't want it's not just that they're have an exhaustion or a trauma or an experience of going to the same house 4, 5, or 6 times or more. But it's usually also the other piece of this that I think sometimes we don't remember, is that a lot of these EMS workers grew up in these towns, grew up in these neighborhoods, know these people. This is not a stranger pickup, even if you've done it multiple times. They usually have some connection to that individual. It might be that person went to their high school. Maybe they didn't know them in high school. Person went to their high school, lived in their block, dated their cousin. It's like these weird interconnections that it's not as simple as a run, number one. And it's not as simple as a run to the same place. It's not as simple as a run to the same place for a person who's overdosed. It kind of keeps going and going and going. It's very, very layered and nuanced. And so I think that, I think of, the example or the analogy that you gave of, trying to get people to understand kind of what this means about making space for others in this moment in time. This issue around race in America is a big one. And I think people are tired. I think people are tired on both sides. But the fight's still not over, but people are tired. I think that we've got, people coming out of COVID, people are tired. I think that we've got so many things. I think it's like it's like rock'em sock'em robots right now. And we've got, we came out of, and again, no matter what side you're on it, we came out of one of the most brutal election cycles I think any of us has ever witnessed in our lifetime. So, and however you are on either side, you've got to be tired because it was so much of a fight. So it's exhaustion upon exhaustion upon exhaustion, and I don't know if any of us truly see have an end in sight. And I think that we talk about trauma, we talk about trauma informed care, and I didn't think we were going to make it to a whole hour of this, but here we are. And but I think that the other piece, and I was thinking about this today in my own life, is that I've got like about 6 projects that I'm juggling right now. And I was on a call this morning and someone said, and I'm just simply exhausted. I just have no more energy. I can't do another thing. And I was ready to bang my head on the steering wheel where I was taking my 3rd Zoom call from because I had been stuck in traffic longer than I anticipated. So I had all of these stressors and I was like, but when do we all, how do we all make sure that we're incorporating self-care into our own regimen?
Mm.
You know, and that when I was listening to you just now, I started to just really remind myself and think to myself that one of the things that all of us, no matter where we are in this, need to do is a better job, I think, of self-care. And I know that was hard in a pandemic, but you know, even if it's a, you know, you don't take Zoom calls after 3 o'clock, or you take a day, a real day off where you truly unplug, you know, or, you know, I told somebody, you know, I really, one of the ways I manage my anxiety and do self-care is I really kind of think of other ideas and projects. But I think that we have to do that. We have to do the self-care piece because you said it, you know, some of us are going to come, some of us are going to come at this as warriors, and some of us are going to come at this as healers. But in either case, both of them are energy zapping. And so where do you replenish? Because this fight is far from over.
I think that's a really great point, Tony. And I think that like throughout this call, like you've been teaching me, like I often say too many words. So we're going to see if I can do any learning and do a little less of that with the 3 last things that I want to say. I really love what's been in the chat box about from Catherine and from Martha. And the need to meet people where they're at. And so like part of knowing where someone is in their stage of change, knowing what conversation you're having is to listen. And is to meet folks where they're at, just like with the stage of change, also something that's useful to our community partners, to our broader community, as it is to folks who are dealing with a substance use disorder. The second part that I want to talk about, and I want to talk about it as sort of a consultant whose job title is technical expert lead, is the limitations of expertise and the lack of vulnerability. And so I think that what would help me, I put my email in the chat box. Anyone who's been listening to this and thinks that like this guy is completely out to lunch, feel free to reach out to me and we'll have a conversation about it, because I would love to learn the ways that's true. Or if you think,
Uh-oh, you went on mute. I don't know what you hit, but you went on mute. Uh-oh. Uh-oh. And you were on a roll. It wasn't a lot of words, and it was really good. So while he's figuring that out, so one of the things is that it just came up in the chat box. And let's see if you're back now. Uh-oh. Nope, now you're on mute again.
Can you hear me?
Now I can. There you go. Bang.
Great. And so feel free to reach out if you think that like, I like what he's saying, but the way he's saying it's not going to work where I am, or I like everything he's saying, but like it doesn't make sense where I am. So I think that like, because we've got this idea of expertise, we don't have the listening that's being sort of championed and described in the chat box. And there's a real need for that, because also folks who do some jobs like mine, they're sometimes tired and they're not doing things in the right way either. And we're not meeting each other. We're not hearing each other. And the last piece and the last thing that I have in the chat box is a TED Talk by one named Heather McGee. And the title of the TED Talk is Racism Costs Everyone. And so not just racism, but the other things that we're talking about. Someone also in the chat box said people in neighborhoods are tired, right?
Mhm.
Quality of lives have been very altered. Yeah, no,
Yeah,
that makes a lot of sense. And Kim sort of underlined the point that I wanted to speak to. And that's a big part of what we're seeing drive some of these syringe service program laws, right? And because people are tired, they want a simpler solution, and they want to get rid of the thing that for them symbolizes the things that they're tired of.
yeah,
And we also know that as a result of these laws, people are going to die, and things are not going to get cleaned up. That's not how it works. It's not how it's ever worked. And so there's going to be a cost to everyone, right? So I think the thing that we can only do if we form relationships and if we listen is to help figure out how we get less tired and more free. Because some of the things we want to do when we're tired are going to be either burning the furniture to keep warm. They're going to be short-term thinking, or sometimes they're just going to be making the problem worse by going with some of our lesser instincts. But those are the three things I wanted to leave with.
you know, Andrew, I want to thank you so very much for allowing me to pick your brain and pick on you a little bit. Thank you for pitch hitting. I will beat Shawn with a wet noodle later. But I think also I want to thank Martha, and I want to thank Martha and Kim and Catherine for their comments in the chat and for participating in the talk. So Martha, I think you were certainly in the right place at the right time. I'm glad you stumbled into here. And so anything that we can do to help you in your state, across the state, we will. And again, it's National HIV Testing Day, the end of the month. I'm asking, if you say, well, I don't do anything about HIV, that's not my workspace. I think you can figure out something to do to educate your clients about HIV and educate yourself as well. Again, thank you very much for taking out an hour of what I know are busy times for everyone to share a little bit and learn a little bit and talk a little bit with us. The syndemic in West Virginia is raging, and join me in the fight to knock it back. Thanks a lot. And thanks, Andrew. Thanks, Amy Snodgrass, my favorite name in the world. And everybody have an amazing week.